Kalyan, you can go ahead.
Yeah. Good morning, everyone. Today, my topic is about basics of RRT. So, we will be covering what are the basic principles of RRT, what are the different types of RRTs we have used, and what is the anticoagulation, what are the different types of anticoagulation we use, and uh, we will discuss about the RRT parts of an RRT mission. Okay. Why we have to know about this RRT is because most of the ICU patient, ranging from 5 to 45% patients will be having AK, and about 4% of them needs RRT. So we should know the basic principles of RRT. So what are the basic principles of which RRT works is one is diffusion, ultrafiltration, convection, adsorption. Okay, what is diffusion? Diffusion is nothing but the movement of the solute, the solute particles from high concentration to the low concentration gradient along along the semi-permeable membrane. Okay, in RRT we use a dialysate fluid to maintain the concentration gradient. So the dialysate here, if you see in this image, there is a dialysate fluid which you use. So the dialysate fluid, it can go along with the direction of the blood, or it can go to opposite in the direction of the blood. So if it is going along the direction of the blood, we'll call it as co-current flow of the dialysate. If it is going opposite to the direction of the blood, we will call it as concurrent direction. Okay, so why it is important to know the direction of the dialysate? Because concurrent direction, when the blood and the dialysate fluid are going in opposite direction, there is a high chance of the concentration gradient between the blood and the dialysate fluid will be maintained, so that the more chances of diffusion to occur. So another key driving aspect is based on the size of the molecules. The smaller the size of the molecules, the more will be the diffusion. What are the basic principles? What are the factors that influence diffusion? One is concentration gradient. The more the concentration gradient between the blood and the dialysate fluid, the more will be the diffusion. And in PD, the concentration gradient decreases in due course, and hence the diffusion also decreases. Okay, and what are the other factors that will affect diffusion are blood flow rate and dialysis flow rate. So if we increase the blood flow rate and dialysis flow rate, the rate of diffusion also increases. But there is a point where beyond which the diffusion does not increase, even with increasing the blood flow rate and surface area of the dialyzer and its efficiency. So the more the surface area, the more will be the diffusion, and the efficiency to particular solute, the more will be the diffusion of that particular solute. So what is the other principle is ultrafiltration. Ultrafiltration is about the solvent. Diffusion is about the solute. Ultrafiltration is nothing but the movement of the solvent from high pressure to a low pressure area. In this, we don't use any dialysate. We use pumps to maintain the high pressure inside the blood, so that the water will be moving, the solvent will be moving from the high pressure to a low pressure area. We have two pressures, one is hydrostatic pressure and is osmotic pressure. Hydrostatic pressure is mostly used in all the CRRT, SLED, SCUF. Osmotic pressure is most works in peritoneal dialysis. What is convection? Convection is nothing but the movement of solutes along with the solvent. Convection is also known as solvent drag. So when we are a solvent drag, when we are using an ultrafiltration, that means we are giving high pressure and there is a movement of solvent. Along with the movement of solvent, the solutes will also be dragged along with the solvent. This is known as convection, and this is also known as solvent drag. So while we are removing your solutes with the ultrafiltration, we need a high ultrafiltrate to be removed, so that the patient will become hemodynamically unstable because of the more loss of fluid. We have to replace the fluid which we are removing by sterile solution. We'll call it as replacement fluids. Okay, see this see this picture. We don't have any dialysis. We are not giving any dialysis in this patient, but we are using pumps so that we will maintain the high pressure in the blood side area, and there will be movement of these small water, blue molecules are water, and other along with the movement of water, there is movement of some solutes. If you observe, the solute size will be middle size molecules or large molecules. So What is other principle is adsorption. Adsorption is nothing but the adherence of the molecules to the membrane. So whatever the membrane or the filter we are using, the larger the molecules will be the membrane will be, when the membrane is exposed to the blood, the larger molecules will be adhered to the membrane. And unlike adsorption, unlike diffusion or ultrafiltration, the molecules will not pass beyond the membrane, and they are not removed through effluent fluid. Here, the molecules will be adhered to the membrane. So there is an increasing interest in the potential of adsorption in sepsis and septic shock, because the inflammatory mediators and cytokines will be adsorbed to the membrane. So once the membrane gets saturated with the molecules, the adsorption will also decrease in the due course of time. Okay, this is a picture showing all the three modalities where three principles where the RRT is working. One is a diffusion, where the movement of the solutes; the other is convection, the movement of the solvent, and along with the solute, solvent drag. And the other picture is adsorption. Okay, so we have to know about what are the different sizes of molecule. We have a small size molecules, medium size molecules, and large molecules. In small size molecules, our main interest is with urea, creatinine, and in the middle size molecules like vitamin B12, we have cytokines, we have inflammatory mediators, and the large size molecules are albumin. So where diffusion works more is in small size molecules. It is the where the diffusion helps in removing the small size molecules more, whereas middle and large size molecules, ultrafiltration and convection are the principles where they work, where they are removed more efficiently. Okay, this is the same thing which we discussed with the small molecules and middle side molecules. What are the different types of RRT used in intensive care? We have intermediate therapies, we have continuous therapies, and there is other therapy called hybrid therapy, which is which has the characteristics of both intermediate therapies and continuous therapies. Coming to what are the intermediate therapy, we have what are the other extracorporeal therapies? We use therapeutic plasma exchange. We have high volume ultrafiltration, pulsed high volume ultrafiltration, ultra high volume ultrafiltration, and coupled plasma filtration and adsorption. Coming to what are the, we'll discuss this about later. Coming to what are the intermediate therapies. Intermediate hemodialysis, it basically works wherever there is a term called dialysis. Dialysis works under the principle of diffusion. Wherever the term called hemofiltration, that works under the principle of convection and ultrafiltration. Okay, so basically intermediate hemodialysis works in the principle of diffusion based therapy, but if we want to remove fluid from the patient, we can add ultrafiltration to this also. So the basic is coming to what is the difference between these therapies. We have the type of mission and duration of therapy. Each therapy has its own duration and the blood flow and the dialysate flow. This is the main point where the difference occurs between the three therapies. See, if we see the intermediate therapies, the duration will be 3 to 4 hours per day, and only three times or 4 times per week. The blood flow, if you see, it is like 350 to 400 ml at a time. The blood flow is very high intermediate therapies, whereas if you see continuous therapies, the blood flows will be like 100 to 250 ml. And the ultrafiltration rate, if you observe, for intermediate therapies, it can range up to 0 to 4 liters, whereas for the continuous therapies, we have 200 ml up to 200 ml per hour. So what is the difference between the intermediate therapies, that hybrid therapies between the intermediate and continuous therapies? So if you see, the duration is like lesser duration when compared to the continuous therapies in prolonged intermediate or hybrid therapy, and the blood flow is compared to lesser than the intermediate hemodialysis, but more when compared to the continuous therapy. So what is the advantage? What is the main things that are different which in intermediate hemodialysis is it has a rapid correction of acidosis and electrolyte abnormalities. Whenever the patient where we need to correct acidosis rapidly, the intermediate hemodialysis will become the first modality of treatment, where we can correct the rapid acidosis rapidly and the electrolyte disturbances rapidly. And rapid removal of dialyzable drugs. If the patient having any drug overdose, if you want to remove the drugs by extracorporeal therapies, intermediate hemodialysis will be the first modality of treatment. And there will be rapid correction of fluid overload because the blood flow rate with the dialysis machine is high, and which helps us to remove the fluid faster. And what is the important this thing it is a short duration of time, 3 to 4 hours. So the exposure of the anticoagulants also will be very less, and it's relatively inexpensive when compared to your CRT, continuous renal replacement therapy. Okay, what are the features of a dialyzable toxin? For a toxin to be dialyzable, to be removed from your renal replacement therapy, it has to be small size and it has to be more water soluble, and it has to be the protein unbound free fraction should be large so that easily dialyzable. What are the different dialyzable toxins? The lithium, methanol, ethylene glycol, salicylates, barbiturates, metformin, and other antibiotics like aminoglycosides, metronidazole, carbapenems, cephalosporins, and penicillins. Why we have to know about the antibiotics? Because if the drug dosing to the patient is highly dependent on the RRT, we have to plan we have to dose the drugs according to the RRT. What are the other drugs which are not removed are digoxin, tricyclic glycosides, beta blockers, benzodiazepines, macrolides, and quinones, warfarin. So, what are the hybrid therapy? Hybrid therapy is also known as prolonged intermittent renal replacement therapy. There are like SLED. SLED is sustained or low efficient daily dialysis. SLED F is nothing but sustained low efficient daily dialysis with filtration. So we know that dialysis, we use a dialysate fluid, and it mainly works under the principle of diffusion. Whenever we add a filtration, here ultrafiltration and convection will be added. So what is the main difference? As we already discussed, it is difference is the we can use the same HD machine for SLED also, but the blood flow rate and dialysis flow rate and the duration of the session and the ultrafiltrate, those are the difference between the intermediate and this hybrid therapies. So it can run up to 8 to 12 hours, and it can blood flow will be from 100 to 150 million, dialysis flow is 200 to 300. So what are the advantage of SLED over CRT? Because SLED, it is an intermediate therapy and it is less expensive when compared to CRT, and the anticoagulation which we use is less when compared to CRT, and it has a similar adequacy and hemodynamics as CRT. Maybe not very much similar, but it is similar. What are the continuous therapies? We have CVVH. CVVH is nothing but continuous veno-venous hemofiltration. CVVHD, nothing but continuous veno-venous hemodialysis, and hemodialysis and filtration. The other thing is SCUF. SCUF is slow continuous ultrafiltration. So why continuous therapies are used? It is continuous therapies are used more in hemodynamically unstable patient, where high blood flows can result in deleterious effects to the patient. So the continuous therapies have a low blood flow rates like 100 to 200 ml. Then we have a continuous continuous venous hemofiltration, where we have to remove more ultrafiltrate like 20 to 40 ml per kg. So we have, in order to remove such a, we are removing so much fluid, we have to replace the fluid with replacement fluids, sterile fluids. And what is, as we know, dialysis, whenever the dialysis, we'll use dialysate. And in veno-venous hemodiafiltration, we use the both techniques of dialysis, diffusion, and ultrafiltration. So if you see this picture, this is SCUF, slow continuous ultrafiltration. This is ultrafiltration, and it is slow process. And we are not giving any dialysate to the patient. We are only removing the fluid. That is nothing but the effluent. In case of continuous veno-venous hemofiltration, in this continuous veno-venous hemofiltration, if you observe there, we are giving a replacement fluid to the patient, but we are not giving any dialysis, and we are removing the ultrafiltrate in the form of effluent. Okay. See, this is continuous veno-venous hemodiafiltration, where we are not giving any effluent fluid to the patient, but we are using this process of diffusion using a dialysate, and we are removing the effluent. Okay, and this is a combination of both diffusion and ultrafiltration. If you see, there is a replacement fluid and there is a dialysis. We are using both the techniques of diffusion, and also we are using hemofiltration, removing the ultrafiltrate through effluent. Okay. So what are the advantages of CRRT? Why CRRT is more important in ICU is because most of the ICU patients are hemodynamically unstable, and there is other organ involvement like raised intracranial pressure, where we and cardiac instability, where we cannot suddenly change the osmolarity of the blood, and we don't want any sudden change of fluctuations in BP. In this kind of set of patients, CRRT is our first treatment of choice. So it's a continuous treatment, and it is more. We can remove unlimited fluid and waste removal, and elimination of it is also useful in sepsis because of the we can eliminate septic mediators like cytokines, interleukins, and it requires continuous. It is a disadvantage. It requires continuous anticoagulation, but as compared to intermediate therapies. So, what is the difference between CRRT and ISA? As we discussed, it has a better preservation of cardiovascular stability, and also in patients with ICP raise, where we don't want sudden osmolarity changes, CRRT is of much use, and it has more effective clearance of middle-sized and large-sized molecules, whereas intermediate hemodialysis, there is more of small molecules. And we can remove immunomodulatory substances like cytokines, endotoxin, interleukins, as we already discussed. It has better fluid maintenance when compared to the IHD. Where IHD, what is the main advantage is it's an intermediate therapy. Patient can be easily mobilized. We don't give prolonged duration of anticoagulation, which will reduce the bleeding complications to the patient, and it is less expensive than CRRT, and it has less chances of filter clotting. Okay. What is peritoneal dialysis? Peritoneal dialysis is nothing but we dialyze the patient using a percutaneous peritoneal catheter, PD catheter, in where the main mechanism of solute removal is by diffusion, where fluid removal is by osmotic pressure difference. Okay. What are the? We discussed so much about the we have to give the replacement fluids to a patient who is undergoing hemofiltration. So what are the different kinds of fluids we have? We have one is bicarbonate fluid or any other solution which replaces bicarbonate, like lactate, acetate, and citrate. These are different kinds of replacement fluids we have, and the replacement fluid choice will depends upon the patient's acid-base balance, and also the they depend upon the electrolyte disturbances. So what is the where we have to give a replacement fluid? There are if you see this picture, the replacement fluid can be given pre-filter or post-filter. What is the advantage of giving the pre-filter replacement fluid is that one is that it will the hematocrit in the blood will be diluted, so that the filter clotting will be decreased. But there is also a disadvantage that once we are diluting the pre-filter hemoconcentrate, the amount of solutes that we are clearing is also reduced. Compensatorily, we have to increase the ultrafiltration that will further worsen the hemodynamic instability of the patient. Coming to lactate-based solution, they are more cheaper, they are more practical, they have greater stability. But there is a downside for this lactate-based solution where it has to be metabolized in the liver. But in patients where there is a liver failure or lactic acidosis, where lactate is not being converted into bicarbonate, that can further worsen the acidosis and can be detrimental to the patient. So if you don't have any other fluid options, but if your serum lactates are not very much high, but you can use the this lactate-based solution along with the bicarbonate infusion. Coming to bicarbonate replacement solutions, they are more reliable. They have to be prepared just prior to this. They have better hemodynamic stability and are more preferred in critically ill patients. But the undesirable side effect is they will trigger the inflammatory mediators. Coming to acetate-based solutions, they are not routinely used, not used because of the deleterious effects on the hemodynamics. Coming to citrate-based solutions, citrate based solution, citrate acts as both as a replacement fluid as well as an anticoagulation. So this is a new generation buffer fluid, can be used as a buffer and as an anticoagulation. But the thing is, it requires meticulous monitoring because of all the side effects it has with the electrolytes such as hypocalcemia, hypophosphatemia, hypomagnesemia. So we need to regularly monitor the electrolytes, and we have to adjust the dose of the citrate solution. One citrate can metabolize into 3 bicarbonate ions, where metabolic alkalosis is one of the side effects. So as we discussed, the choice of the replacement fluid has to be depends upon the acid-base balance, depends upon the electrolyte disturbances and organ dysfunction. We cannot give a lactate-based fluid for a liver failure patient. And so, what is a filter? What is a filter and membrane? Filter and membrane is nothing but, if you see this picture, this is the filter or a membrane where the blood is entered into the filter, where the ultrafiltration or diffusion take place and the blood is pumped out. So we have to know about the filters. So the filter membrane composed of 10,000 hollow fibers with diameters approximately 200 micrometers, and thickness of the membrane is between 20 to 50. This filters are made up of either cellulose or synthetic polymers like polysulfone and polyamide. So what are the features of these filters? What are the properties? One is biocompatibility. Whenever the blood touches a foreign material, it will activate the coagulation pathway and inflammatory mediators will be activated. So if the membrane has to be more biocompatible so that the activation of this inflammation will not happen. So the degree of the activates the inflammatory is known as a biocompatibility. And what is a flux? Flux is nothing but the permeability of the membrane. So if we say that membrane is high flux membrane, that means they are more hydrophobic and they have larger pores, so that the fluid is can easily flow through the membranes, allowing it's nothing but the permeability of the filter is very high. So what is adsorption? As we already discussed, adsorption is nothing but the adherence of the molecules to the surface. As the RRT continues, the adsorption capacity of the membrane will decrease because of the saturation. What is surface area? As the more surface area of the membrane, the more will be the diffusion and ultrafiltration. So what are the characteristics of the membrane? The pore size affects the solute transfer, and along with the other electrolytes, phosphates are also lost as the same as urea. So it also removes glucose. That's why the main reason for regular checking of GRBS to the patient on RRT is there is a constant removal of glucose from the patient's blood. There is a high chance of patient going into hypoglycemia. So we have to check GRBS regularly to prevent the hypoglycemia. And there is a clear, it does not secrete toxins like a tubular cells. So most filters we use the synthetic filters which have high flux and also high biocompatible with a surface area of 0.6 to 1.2 meters square and a pore size allowing molecules up to 50,000 Daltons. Okay. Coming to the anticoagulation, what are the anticoagulation we use in RRT? Why do we have to anticoagulate the patient? Because the major problem in the renal replacement therapy is clotting of the circuit. Because of the clotting of the circuit, the efficiency of the dialysis will come down, and the life of the filter will come down, and also there will be a loss of blood in the circuit because of the clotting. So why it is happening? Why blood is clotting is because in patients with AKI, when there is a renal dysfunction, there will be reduced clearance of circulating cytokines and other inflammatory mediators. So AKI can trigger both intrinsic and also extrinsic coagulation pathway, and also there is decrease in natural anticoagulants like antithrombin 3, heparin, cofactor 2, protein C, and protein S. These are the different mechanisms where why there is an increased coagulation in the circuit, and what are the other mechanisms are venous access catheters. Whenever we are keeping a HD sheath to the patient, there is an endothelial damage, and also there is a release of tissue factor which will further trigger the coagulation. And non-laminar flow. In circuits, there will be a non-laminar flow, and which will activate leukocytes and platelets. And whenever we're using a pump to suck out of the blood from the patient, that can also trigger leukocytes and platelets. So if the filter which we are using is bio incompatibility is present, that will trigger the activation of platelets and leukocytes. And the this biomembranes, dialysis membranes are negatively charged. Contact with blood potentially generate bradykinin and activate factor 12 and initiate thrombin generation. So, if there is air in the venous, in the blood, in the circuit, that can also increase the thrombus formation. So, we have to make sure that there is no air in the circuit. During CRT, the blood flow will be slower and ultrafiltrate rates will be higher, but this can lead to further risk of clotting. So, what are the non-pharmacological measures to reduce the coagulation? So, we have to optimize the vascular access. The flow from the vascular access should be good, so that there will be no interruption to your hemodialysis. There will be no interruption to your flow that will prevent the that will cause, if there is any interruption, that will cause a coagulation, that will clots in the filter. So the diameter and the flow should be very good, and the CRRT setting should also be optimal. And if there is a pre-dilution in the pre-filter, if we give a replacement fluid, that will prevent the clotting in the circuit. And also we have to train nurses and attendants to attend the alarms immediately, so that there will be no stopping in the flow in the circuit. What is the ideal anticoagulation? If you want to give an anticoagulation, what are the ideal features of an anticoagulation? It should be readily available. It should selectively be active in only circuit, and it should not affect any patient condition. It should prolong the filter life. Ideally, it should be more than 48 hours. And the monitoring of the anticoagulation effect should be rapid and should be simple. It should be rapidly reversible in case of complications. Antidote should be easily available. The staff has to be easily trained, and there should be simple protocols, and it should be cost effective. Whereas we don't have any ideal anticoagulation fulfilling all these criteria. We have, what are the different kinds of anticoagulation are systemic anticoagulation and renal anticoagulation. Systemic anticoagulation is used in patients who are having systemic illness, where we are giving anticoagulation. In such kind of patients, we don't have to add an extra anticoagulation to the RRT. But what is the backdrop is, it might lead to inadequate anticoagulation and filter clot. Regional anticoagulation is optimal, where anticoagulation of the filter without causing any systemic side effects. But it is a tedious process. It has to be monitored. So, what are the different agents we use for anticoagulation? We use heparin, low molecular weight heparin. We can use citrate. For regional, we can use regional heparin, saline flushes, and prostacyclin. So, we already discussed what are the things we have to do without anticoagulation. What are the crucial steps in maintaining setting up a circuit? Is we have to keep a tight connection to prevent the air entry. Air contact with the blood can trigger your clot forming. Good priming with 0.9% saline and heparinized saline. Intermittently flushing the circuit with 100 to 200 ml of NS, and pre-dilution of the replacement pre-filter will decrease the hemo concentration, and it prevents the clotting. So, coming to unfractionated heparin, pharmacologically, unfractionated heparin acts it binds to antithrombin 3, and it also inhibits factor 2A and also other clotting factors. But what is the normal half-life is 0.5 to 2 hours, and it can be increased to 3 hours in AKI. What is the loading dose? We give 10 to 20 units per kg, followed by 5 units per kg per hour. What are the advantages of unfractionated heparin? It is effective. It is widely available. It has a simple monitoring. We monitor APTT. It is reversed with protamine, and it is inexpensive and short half-life. Disadvantages are, it can cause systemic bleeding. It has unpredictable kinetics in case of renal failure. And APTT is a not reliable predictor of bleeding. Heparin resistance can occur in the form of HIT, heparin-induced thrombocytopenia. And the other thing is low molecular weight heparin. It is smaller than unfractionated heparin. They cannot bind antithrombin 3, but it has an effect on factor 2A. And What are the advantages of low molecular heparin? It is effective. It has a predictable pharmacokinetic and lower incidence of heparin-induced thrombocytopenia, cytopenia. And disadvantages are systemic bleeding is there, only partially reversed with proton. And anti-tenia activity, it's expensive also. And what are the other things? The direct thrombin inhibitors like argatropan. Argatropan is a second generation direct thrombin inhibitor agent of choice in patients with heparin-induced thrombocytopenia. The half-life is between 35 to 50 minutes, and loading dose we have to give by 100 to 300 micrograms per kg, and the maintenance dose of zero point 0.1 to 2 micrograms per kg per minute. Dose adjustment in patients with liver failure, because it is mostly metabolized by the liver. So monitoring is usually done by APTT. It has to be 1.5 to 2 times the baseline. Effect wanes off in 2 to 4 hours after stopping the infusion. No specific antidote is required, as it wanes off in 2 to 4 hours. Coming to citrate anticoagulation, how citrate is going to work is, citrate is a chelating agent which reversibly binds to ionized calcium. So calcium is the main substrate for coagulation in our clotting pathway. You can see it helps in activating many clotting factors. So if we prevent the calcium by chelating it, the coagulation pathway is also affected. So that's how citrate works. And how we will give citrate is a trisodium citrate. Usually, it's a 40 mg mixed in 1 liter, 5% dextrose, and is usually started at 180 ml per hour. So citrate, and it can be used both as a replacement fluid and also as a anticoagulant. But what is the main side effect of citrate based solution? It can cause hypokalemia. So frequent monitoring of calcium should be done, and our objective is to maintain ionized calcium uh, in the circuit between 0.225 to 0.35 millimoles per liter. And depending upon the ionized calcium, we have to replace the calcium to the patient. If you see, we are giving a citrate anticoagulation here, and we are measuring the calcium. Your dialysate fluid should be calcium free. Otherwise, the amount of the citrate we are giving will be will be increased. It has the dose of the citrate has to be increased, because more of the calcium is present in the dialysate fluid, and we have to monitor the calcium, and we have to replace the calcium to the patient. Okay. So this is the same diagram which was showing. When we are giving a citrate solution as an anticoagulant, and replacement fluid should be calcium free, and we have to measure your calcium and you have to replace it. So preferably to use calcium free dialysate, because it will minimize the citrate requirement. So after citrate is mostly acts in the circuit only, but if it enters the patient, it will be metabolized by liver, kidney, or skeletal muscle with no anticoagulation effect on the patient. So what are the advantages of citrate? It has less complication. It will increase the long filter life. It has a less downtime, delivered lesion, lower cost. But if the patient is receiving more citrate, if it enters the patient circulation, if it metabolizes, then it will cause alkalinization by increasing the bicarbonate. But if it doesn't metabolize, it will cause acidification, which will cause hypothermia, electrolyte disturbance, and blood loss to the patient. If you see this citrate intoxication can cause decreased calcium, will cause severe hypocalcemia, which will have a myocardial effect on myocardial contractility. But if there is citrate accumulation, which is not metabolized, which is which is in the absence of sodium or bicarbonate generation, it will cause metabolic acidosis, which will also decrease the myocardial activity and cause death to the patient. And what is the importance of calculating total calcium to the ionized calcium in case of citrate anticoagulation? Because whenever we are giving citrate, whatever the anion based calcium here, if you see that it increases in case of citrate, increased citrate levels. So if you have to monitor the total calcium to the ionized calcium, if it is more than 2.5, we have to correct the calcium. What are the advantages of citrate anticoagulation? It has a shorter half-life. It will prolong the CRRT filter spans. It has a reduced occurrence of bleeding. Safe to use in patient at risk of heparin-induced thrombocytopenia. It produces 3 molecules of bicarbonate, and in patients with severe metabolic acidosis, it will be help. What are the disadvantages? In inability to metabolize, in case of liver failure, it can cause citrate toxicity, or citrate uh, increases the acidosis. See, complex citrate protocol is very complex, and it needs a more number of people, multi-systemic approach, and it can cause hypocalcemia, hypomagnesemia, and it's a trisodiate citrate solution where sodium is very high, and it can cause hypernatremia. So what is the monitoring we have to do in regional citrate anticoagulation? We have to monitor sodium, potassium, ionized calcium, ABG every fourth hourly, and we have to monitor daily calcium, phosphate, and magnesium. Uh, as we told, total to ionized calcium ratio should be less than 2.5. If it is more than 2.5, it's mostly because of the citrate binding to the calcium. So what are our targets? Your systemic ionized calcium should be between 1.1 to 1.25 millimoles per liter, and post-filter calcium should be less than total to this should be less than 2.025. Okay, there is no perfect anticoagulation. As we discussed, what are the ideal characteristics of anticoagulation? We have to give anticoagulation based on the risk versus benefit ratio. We mostly use heparin anticoagulation or citrate anticoagulation. Choice of anticoagulation is decided by the physician. So what are the recommendations? We recommend, what are the recommendations? We have to give anticoagulation to the patient who has no increased risk of bleeding. So patients who are on systemic anticoagulation for other systemic conditions, where we don't have to give an extra additional anticoagulation in this patients. If we recommend unfractionated heparin during intermediate hemodialysis and regional citrate anticoagulation in CRRT settings. When there is a patient with impaired coagulation or increased risk of bleeding, there is a recommendation not to use any anticoagulation. Okay, what is the main thing? So what is the dosing of RRT? Dosing of RRT is, so we are starting a patient on we have decided to start a patient on hemodialysis. Now we know what kind of modality we should use. Either it is an intermediate therapy, or it is a hybrid therapy, or a continuous therapy, depending upon the patient condition, hemodynamic instability, and also the how fastly we have to correct the acidosis or electrolyte imbalance. Depending upon that, we will choose our modality of RRT, and also we have to dose how much we have to remove the ultrafiltrate, how much hours we have to do the RRT. That is, we call it dosing of RRT. Dosing of RRT is nothing but it is calculated based on the clearance of the urea as a surrogate for low molecular weight uremic toxin. So this modality of clearance of urea is mostly we use in we have two things, that is urea reduction ratio and KT by V. This thing we use mostly in intermediate hemodialysis and CKD patients where they are having weekly thrice dialysis. So what is KT by V? Clearance is nothing but volume of the blood cleared of urea for a given time. How much, when we start a dialysis to the patient, how much of the urea that is cleared per unit time? Okay, what is the intensity? So it is nothing but the clearance, that is volume of urea that is cleared per unit time into how much duration we are giving the therapy, that is RRT. Generally, when intermediate hemodialysis, we give 3 to 4 hours. So what is the efficacy? That is that KT by V. The KT by V is nothing but the volume of distribution. That is how much normally for a male patient for 60 kg weight, that will be 0.6 into 60. Depending upon that, we will get a volume of distribution of the urea. So if we substitute all these values, and we will get value, normally our KT by V should be less than, it should be more than 1.3. In target has to be more than 1.3, so that the delivered dose is at least 1.2. In peritoneal dialysis, the target has to be more than 1.7 per week. KTBV cannot be measured in a critically ill patient, because in a critically ill patient, the volume of distribution is altered, hemodynamic stability is altered. So we cannot measure exactly our hypercatabolic state. in a sepsis patient, in a hemodynamically unstable patient, we cannot measure the exact KT by V. So we use in a hemodynamically unstable patient, we generally use CRRT. So KT by V, that is the urea clearance, is estimated by effluent flow rate in CRRT. Okay, since um, since the urea removal during dialysis is proportional to the blood urea concentration, the absolute urea removal is greatest at the start of treatment, because if you remember the diffusion, it is depend upon the concentration gradient. So initially the concentration gradient between the blood and the dialysate fluid will be high, so initial clearance will be very high. So it is if the same weekly duration that we are doing for 3 to 4 days, the intermediate hemodialysis is divided into small intervals like 2 hours for 6 times per week, the effective weekly solute clearance will also be increased. What are the limitations of this KT by V, the urea kinetic models? Because there are multiple limitations. Because basically, while prescribing a intermediate hemodialysis, we assume that the patient is like volume status is stable and the nitrogen balance is relatively stable. So assuming that these are stable, we dose the intermediate hemodialysis. But in patients in ICU, mostly the patient will be hypercatabolic and in negative nitrogen balance. So in addition to the alterations in regional blood flow in hemodynamically unstable patient, there will be alteration in renal blood flow and also disequilibrium in urea distribution. In this kind of patient, we cannot use this KT by V. So what is the dosing of RRT in CRRT? In CRRT, the dosing is done calculated by the effluent rate. Solute clearance can be calculated by the ratio between the solute concentration in the effluent and multiplied by the plasma multiplied by the effluent flow. The effluent flow is equal to the ultrafiltration. See, it's effluent is nothing but the ultrafiltration in case of hemofiltration, and dialysate fluid which you are giving in the hemodialysis. If the patient is undergoing hemodiafiltration, effluent is a combination of the ultrafiltration and also the dialysate fluid. Okay, the smaller solute clearance is approximately equivalent to the effluent flow. So, but if you are giving a pre-filter administration of the replacement fluids, there will be a dilution of the pre-filter blood hematocrit dilution, and there will be decreased solute clearance will also be there. At that time, your the effluent fluid which you are calculating the dialysis will be 15 to 20% lesser than the normal patients. So typically, how we have to dose a CRRT patient, our effluent rate should be 25 to 35 ml per kg per hour. The dose of is nothing but can thought to be as the volume of the blood purified per unit time. In clinical practice, as we discussed, more definitely the dose is the clearance rate of a representative marker of solute, usually indicated as liter per kg per hour. What are the complications of overdosing? If we overdose the patient, if we remove more ultrafiltrate very fastly, what will happen? Mostly the electrolyte disturbances will happen to the patient, like hypophosphatemia, hypokalemia. Hypophosphatemia can cause respiratory failure and it can delay the ventilator weaning. It can also cause rhabdomyolysis to the patient. Hypokalemia will cause cardiac arrhythmias, and also it also can cause difficulty in ventilator weaning. Because of the intensified RRT, the patient will also land up in nutritional deficiency because of the loss of amino acids and proteins that happens during the RRT. Okay, so what are the different parts of RRT mission? So we regularly see RRT mission in ICU. We have to know what are the different parts. This part is the monitor of the RRT mission, where we can see how much ultrafiltrate we are removing, what is the blood flow rate. We have the alarms for different venous pressure, arterial pressure. That is your first part. And we have blood pressure monitor. In a patient with the undergoing dialysis, we continuously monitor blood pressure to know if there is any hypotension happening. So what is the third one? Third one is the extracorporeal blood circuit module. Where we'll connect our dialyzer, we connect all that, we will connect our dialyzer, we connect all the tubings where the blood coming from the patient and blood going to the patient, we connect our tubics here. And what is the concentrate connectors? Sorry. So concentrate connector is nothing but where we connect our bag or bicarbonate fluid bag, and where these two tubes, they will connect to the acid solution, that bicarb bag, acid solution, and RO water, which combines to form our dialysate fluid. And we have a status indicator. We have a status indicator on top of the machine that will tell us if there is any alarm in the patient. The status indicator will change that. On the back view, we have a sampling valve. See, this sampling valve is present at the dialysate fluid connector, where we can collect the samples and check for the dialysate fluid sampling. And this dialysate outlet tube and inlet tube, these two tubes, which are dialysate inflow tube and outflow tube, as we know, to give the dialysate to the filter. Disinfection connector. Disinfection connector is nothing but whenever the dialysis is completed, if you want to disinfect the machine, we have a fluid that will be kept here, so we can disinfect the RRT machine. And what are the important things? Alarms. We have alarms for blood pressure within the machine, and also if blood flow alarms will be there, and also the temperature alarms will be there. And we have pressure monitor. Arterial pressure monitor is if there is any pressure difference between the blood access and the blood pump, there will be alarms. And we have venous pressure monitor. It is normally detects a positive pressure. Whenever there is an increase in pressure in the circuit, that will be pressure monitor will be triggered. So what is air leak detector? If there is any air in the circuit, that this air leak detector will be alarmed, so that to prevent the air embolism. Thank you. Hello, sir.
Yeah, Nandakishore.
Yes, sir. Thank you, Kalyan. That was a comprehensive review of the basics of RRT. I think one should understand well about the RRT machine before understanding the principles. I think all of the intensivists should remember one thing, is they should sit with the technician, understand the machine, study the different parts of the machine before they go and actually prescribe what, because we are the persons who will be dealing with the emergencies. Any patient landing up with an acute kidney injury, or you're dialyzing for a metabolic acidosis or a hyperkalemia, you should know, or you should understand the basics of your machine is the take-home point. The second thing, as Kalyan told, the various processes of RRT, whether it's a diffusion, whether it's a convection, or whether it's a combination of different principles, you should understand the various types of RRT is the take-home point. And the rest of the part is very well covered. That's the only thing I think we need to understand from this.
Ghanshyam.
Thank you, Kalyan. I think it was, very lucidly explained the various basic aspects of renal replacement therapy in intensive care unit. And I think as intensivists, we need to have a working knowledge about, the different modalities of RRT. If you see, RRT is probably the first extracorporeal organ support that was started, and it's been there for a long time. And when we are on night shifts, or when we are in the emergencies and a patient has to be put on dialysis, then until unless you know the modalities, until unless you know how to dose the RRT, until unless you know what are the complications, giving orders or troubleshooting a patient on RRT might be difficult. So that is where it becomes very important that as intensive care specialists, we should have a comprehensive knowledge about what RRT is all about. Identify the different modalities. Please go back to your units, look when a patient is on RRT, what type of modality you are using. When would you use a replacement fluid? When would you use will not use a replacement fluid? Whether your RRT is sufficient, when will you extend the RRT, duration of RRT, what type of RRT you are using? I think these are very, very important, just like when you put a patient on ventilator to know what are the different modes, weaning. So I think it's a good review by Kalyan. Thank you, Kalyan.
Thank you, sir.
Thank you, Kalyan.
Thank you.
We have understood most of the things about RRT, the principles of RRT. So next week, we will look at a few issues which are controversial, which are a little dicey, like timing of RRT, the modality to be used, certain other aspects of RRT. That will be done by Dr. Shabir and will be guided by Dr. Kadir. Those of you who have logged into this talk today, if you have any queries on what has been discussed today, please do post them on the same WhatsApp group on which you got the link. We will be, one of us are on those groups, so we will be able to answer them during the course of the day. It doesn't matter whether you post it now or an hour later. If you can post any queries on the group in which you have seen the link and the PDF flyer, we will be happy to see those queries and answer them. Thank you very much for joining us. Please join us again next week.
Thank you, sir.
Thank you, sir.